Hello and welcome, guys. Another power packed session of anesthesia is about to begin. This is me, your mentor, your friend, your guide, Dr. Hitesh Nathani, on this awesome, amazing platform of Unacademy. You're watching me on YouTube. The name of this channel is Unacademy Live NEET PG. All those who are watching on the YouTube, please don't forget to hit the subscribe button and the bell icon so that you get the notifications on time and whenever we are coming up with next series of lectures. Where else can you find me on? You can find me on the Unacademy Plus batch course. Here's the link that I am taking the current batch course, that is concise course in anesthesia. The another batch course that I am taking, this is an integrated batch course in which we have just concluded the session of anesthesia from the purview of hematology. And you can find me 24/7. You can contact me, you can message me on this Telegram group, which is by the same name, that is Anesthesia Simplified by Dr. Hitesh. And also to tell you that we are coming up with the special classes marathon this weekend, that is 1st and 2nd of August. This will be a marathon which will go on from 4 p.m. to 11 p.m. and I'll be taking a free session for you on this special class on the anesthesia, that is Anesthesia Achievers Club. It will be a MCQ based session where it will be a wonderful quiz based interaction where we can interact with each other and you can know how you're progressing throughout the course of this series of special classes. It is on 1st and 2nd of August, that is this weekend, Saturday and Sunday, and I'll be taking anesthesia at 10 p.m. Yes, so how and where you can subscribe for this class? This is the live class where you will get to see this. Attend just the free live class on the special platform. Just go to the Unacademy app, subscribe for the NEET PG, and you can attend the free special live classes which are there for you. And all those who want to subscribe for the plus session, you can use the code, that is Dr. Hitesh, to avail 10% discount. You can take from 1 month to 24 month subscription, whatever you wish to. On that note, let us begin today's session. That is the first question on your screen right now. A 23-year-old patient is suspected to have ruptured spleen and is supposed to undergo an emergency laparotomy surgery. Yes, his BP right now is 90 by 50 millimeters of mercury, and the ideal anesthetic agent of choice, it was the examiner wants to ask us. Yes, the ideal anesthetic agent of choice, is it option A, that is etomidate, option B, that is opioids, option C, that is remifentanil, option D, that is halothane. Yes, just by looking at the options and by way of application of logic, you can rule out very easily two options here. Yes, let us look at first what the examiner expects us from. Yes, he is a 23-year-old male patient or female patient. There is a evidence of ruptured spleen. That means spleen is a very much vascular organ, and when the spleen is ruptured, always make sure that the patient is bound to have a hemoperitoneum, and whenever there is profuse blood loss ongoing because of ruptured spleen, splenectomy has to be undertaken in most of the cases if you cannot stop the blood. Yes, and already the patient's blood pressure is 90 by 50 millimeters of mercury. Yes, that means the blood pressure of the patient is already on the lower side. So the ideal anesthetic in this case would be the one which will preserve this blood pressure of the patient. Yes, so if you see at the options etomidate, opioids, remifentanil, halothane, two options can be very easily ruled out, which is remifentanil is what? It is an opioid. Yes, so can you have two same options here? So automatically opioids and remifentanil is ruled out. I am not denying for the fact that remifentanil or opioids are not hemodynamically stable. But considering the question here and the options, it is better to rule it out because we have got other better options here available. Yes. Etomidate and halothane. Amongst this, which of the following is cardiostable? That means I've got no effect on heart rate and no effect on blood pressure. Yes, which of the following agent, anesthetic agent, has got least effect on heart rate and blood pressure? Etomidate, does it cause any increase or decrease in heart rate when it is given? No, it does not. What about blood pressure? Blood pressure, or we can also call as mean arterial pressure in this case, etomidate does not have any effect on blood pressure as well. So etomidate is cardio stable, has got no effect on heart rate, has got no effect on blood pressure. Let us compare it with the other option, that is halothane. What does halothane do on the heart? Yes, what is the effect of halothane on the heart? Remember, halothane is a direct myocardial depressant. What do you mean by this? Halothane acts directly on the myocardium, it acts on the SA node, it acts on the systemic vascular resistance, and it causes decrease in heart rate, and also it causes fall in blood pressure. Yes, because of its direct myocardial depressant activity, halothane causes decrease in heart rate and decrease in blood pressure. So yes, in this case, since the BP is already borderline on the lower side, further decrease in heart rate and blood pressure would be detrimental for the patient. Yes, in this, heart rate is not mentioned, so we are supposing that as the blood pressure is on the lower side, there will be reflex tachycardia. So we are more concerned about fall in blood pressure in this patient, right? So etomidate would be the best answer here, as it is the most cardio stable IV induction agent. Yes, it is most cardio stable IV induction agent. Yes guys, so this is how we have come to the option of etomidate. So whenever a cardiostable IV induction agent is asked, option always has to be, answer has to be etomidate. Moving on to the next question. Which of the following is used in induction of anesthesia? Yes, induction of anesthesia. Remember, it is talking about induction. Induction means, in simple words, making the patient unconscious. From conscious level, in general anesthesia, what we call an induction of anesthesia, making the patient unconscious. Options are bupivacaine, lorazepam, dexmedetomidine, or neostigmine. Let us have a look at the individual drugs and then we'll come to the conclusion. Bupivacaine, what is it? It is a local anesthetic. Yes. Lorazepam, what is it? It is a benzodiazepine. Dexmedetomidine, it is alpha 2 agonist. What about neostigmine? It is anticholinesterase. Where are these drugs used? Local anesthetics, it is used in regional anesthesia, right? To giving blocks for the patient, particularly in central neuraxial blockade and peripheral nerve blockades is where we use bupivacaine. Lorazepam, which is a benzodiazepine which comes under sedative hypnotics. Where all is it used? Predominantly it is used in pre-medication, and it is also used for induction of anesthesia. Yes, if you look at the classification of induction of anesthesia, sedative hypnotics, that is benzodiazepine, comes under slow acting IV induction agent. Slow acting IV induction agent. Yes, which are the rapid acting IV induction agents? Thiopentone, propofol, etomidate, and ketamine. Yes, so lorazepam, that is benzodiazepines, and opioids come under this slow acting IV induction agents. So lorazepam here is the correct answer. What about dexmedetomidine, which is alpha 2 agonist? It is an adjuvant. Yes, it is never used as a sole anesthetic. It is an adjuvant to the anesthesia that you have given to the patient. Yes, also used for conscious sedation. Conscious sedation. Yes. What about neostigmine? It is in fact used to take out the patient from out of the muscle relaxant effect. So it is a reversal agent. Yes. So best possible answer, which of the following is used in induction of anesthesia? It is option B, that is lorazepam. Moving on to the next question. The next question here is anesthesia of choice in induction, for induction in children amongst the following is. Yes, so which of the following is the anesthesia of choice for induction in children, it is asking, right? Option A halothane, option B desflurane, option C isoflurane, option D sevoflurane. So remember, all of these are inhalational agents. Yes, all of these are inhalational anesthetics. So amongst inhalational anesthetics, which is the ideal for induction of anesthesia? Yes, remember, all the induction agents amongst which is a very suitable, which will not cause airway irritation, which has got faster onset, would be ideal choice for induction of anesthesia. Let us have a look into the properties of this. What do these individual inhalational anesthetics cause on the airway? Halothane, whether it is a potent bronchodilator or bronchoconstrictor. Remember, all inhalational anesthetic agents are bronchodilators. But during induction, some of these cause spasm. Why? Because of their properties of smell. Yes, halothane, is it a sweet smelling? Yes, it has got a sweet odor. Desflurane, it is irritant or pungent. It has got a irritant odor. Yes. Isoflurane, yes, it is pungent smelling. And sevoflurane also is got very nice sweet odor. Yes. So automatically desflurane and isoflurane are ruled out because of their irritant pungent qualities, which will cause spasm during induction. Yes, it can be either broncho or laryngospasm. And we do not want any airway irritation during induction of anesthesia. So option B and option C are ruled out. Coming to option A and D, which amongst these two has got faster onset? That means which has got less blood gas coefficient? It is of course sevoflurane. So sevoflurane being have got onset faster than halothane. So patient will be induced faster. And because of its sweet smell, patient does not land up into spasm, that is laryngospasm or bronchospasm. Now remember, it has been asked here children. Even if it was adult here, your best possible answer here has to be sevoflurane. Yes. So halothane is now not preferred as the induction agent of choice when it comes to either adults or children. The only inhalational anesthetic agent that we use for induction of anesthesia, your blind answer has to be sevoflurane. Yes. Moving on to the next question, guys. In CPR, untrue of the following is, yes, in CPR, untrue amongst the following is, it can be given, option A can be given irrespective of the refracture. Option B, in adult, the chest compression is to breath ratio, that is chest compression is to ventilation ratio is 30:2, even when two rescuers are present. In infants, this ratio changes from 30:2 to 15:2 when second rescuer arrives. And option D is the chest compression is at the rate of 100 to 120 per minute in adults and at the rate of 90 per minute in infants. Yes. So what it is asking? It is asking untrue. That means which of the following is false in simple terms. Yes. Most of the times we tend to get confused with these kind of sentences. Untrue, not true, which of the following are true except. So we just have to be a little vigilant while solving such questions. Can be given irrespective of the refracture. Now CPR, is it a life-saving procedure? Yes or not? Yes, it is a life-saving procedure. So will we be worried about the refracture because the patient is already dying? We won't be worried, right? Refracture can be taken care of later, but right now what is important is saving the life of the patient. So it has to be given irrespective of the refracture of the patient. So option C, option A is true, right? In adults and in infants, what are the chest compression is to ventilation ratio? In adults, whether you have got one rescuers or two rescuers, the chest compression is to ventilation ratio is always 30:2. So this is a true statement. Whereas as compared to the adults, in infants, if you have got two rescuers, that means two of you are there together giving CPR to a patient. One can take care of the chest compressions and the other can take care of the maintaining the airway and breath. In that, the ratio of chest compression is to ventilation, if you are alone, it has to be 30:2. But since two of you are there, the chest compression is to ventilation ratio comes down to 15:2. So yes, option B and option C both are true. So what we are left out is automatically option D. Yes, even if you do not know rest of the things, if you just know one thing, that is the chest compression rate according to the 2015 AHA guidelines in adults, in children and in pediatric is same, that is in between 100 to 120. Yes, it should not be less than 100, it should not be more than 120. This is the range that the American Heart Association guidelines has formulated. So whether it is adult, whether it is children, whether it is infants, the chest compression rate is same in all the cases. So option D is untrue, so that is the correct answer here. Yes. Moving on to the next question. The high pressure system of anesthesia machine includes which of the following? Yes. So anesthesia machine, first you should know how is it divided. How do we study anesthesia machine? And accordingly, you will be able to answer that question. Yes. So high pressure system of anesthesia machine includes option A, hanger yokes, option B, oxygen flush, option C, flow meters, and option C, pipeline inlet. So how do we study anesthesia machine? We study anesthesia machine based on this pressure system. Yes, we have divided anesthesia machine on the pressure system into three types. First one is high pressure system, second one is intermediate pressure system, and third one is low pressure system. So let us have a look at the individual pressure systems of anesthesia machine when we want to study the anesthesia machine. Yes, this is how it is divided: the high pressure system of anesthesia machine, intermediate pressure system, and low pressure system. Yes. What are the components of anesthesia machines under the high pressure system of anesthesia machine? The first and foremost that we study under high pressure system of anesthesia machine is cylinders. Very important part when you have to study anesthesia machine. Cylinder form the bulk of the questions when it comes to anesthesia machine. Second, yoke assembly. Third, pressure gauge. Fourth is the pressure reducing valve. After the pressure reducing valve, the pressures from the high pressure systems, now the pressures are converted into intermediate, that is the working pressures. So what are the working pressures in the intermediate pressure system of anesthesia machine? First and foremost, the part of intermediate pressure system is the flow control valves. Second, very important part, that is the pipeline inlet. We call it central pipeline. This you will see running all throughout the hospitals, right from the basement up to the top floor of the hospitals, in the OT, in the ICU. You will see the wiring and the wires and the tubings running all throughout, the pipes running all throughout of different colors: yellow, blue, white, so on and so forth. So these are nothing but these are the central pipelines which are carrying oxygen, nitrous oxide, air, and as well as vacuum pipe, right? Third, all the failure safety alarm devices, all the safety devices which are incorporated into the anesthesia machine are included in intermediate pressure system. Be it oxygen failure alarm device, be it oxygen flush valve. So all the safety features which have got a working pressure as well as for the features of working of the ventilator, these are included in intermediate pressure system. What about low pressure system? After oxygen flush valve, right from the rotameter, that is also known as flow meter. Most of the times they tend to confuse flow meters with intermediate pressure system. Remember, up to flow meters we say, yes, up to flow meters or rotameter, it is intermediate pressure system. After that, it starts with low pressure system. So flow meter is included in low pressure system of anesthesia machine. Next comes your vaporizer, and last one is common gas outlet. So this is how we divide anesthesia machine, and while studying anesthesia machine we study it under the following headings. So let us look at the options that we have. Hanger yokes, is it a part of high pressure system, intermediate or low pressure system? Just now we have seen hanger yoke is a part of high pressure system of anesthesia machine. Yes. What about oxygen flush? Remember all the safety features incorporated into the anesthesia machine: oxygen flush valve, oxygen failure safety devices, oxygen failure fail-safe alarms are incorporated into intermediate pressure system of anesthesia machine. Flow meters, just now I told, up to flow meters it is intermediate, from flow meter onwards it is low pressure system of anesthesia machine. Pipeline inlet, again very important part of the intermediate pressure system, as well as from the hospital point of view, pipeline inlet is one of the very important parts. The correct answer here, that is high pressure system of anesthesia machine, includes option A, that is hanger yokes. Moving on to the next question, guys. The anesthesia of choice in daycare surgery. Daycare surgery means what? First we'll have to look into that, and then we'll go on to the options. The options given here: ketamine, thiopentone, halothane, and pancuronium. So which of the following amongst this can you use for the daycare surgeries, right? So you will have to look into the options which are suitable for daycare. What do you mean by daycare? Yes, I would like to add one more option here, but since it has not been given here, we will not go into the details of that. But since most of the drugs that we use in the daycare surgeries are what, and what is our preference for that? Yes, first have a look at what do we call it by a daycare surgery. Daycare surgery means like your daycare in the children, that we call it, right? Children who does not go to school, or even after school we generally put them into daycare, right? What do you mean by daycare? Where the children goes, stays for 5-6 hours, does all the work, and then we get it back. Yes, because we are working professionals. The same way, daycare surgery means a patient comes in the morning, gets operated, and gets discharged by evening or night. So that is meant by daycare. In the morning he comes. The best example for daycare surgery is cataract surgery. Every one of us must have seen cataract surgeries in our households, for our elderlies, or even in our neighborhoods. The patient goes to the hospital in the morning, gets operated, and is back by evening or night the same day. That is meant by daycare surgery. So which type of anesthesia is suitable for daycare surgery? One, you should know that. And what are the drugs that we use in daycare surgeries? Remember, all the drugs which are short acting. Short acting drugs is what we use in daycare surgeries. For IV, ideal drug is what? And for inhalational, what is the ideal drug that we use? Yes, for IV we generally prefer propofol is the ideal drug for daycare surgery because of its rapid awakening profile, and for inhalational we prefer desflurane because of its rapid onset and same way rapid recovery. Yes, but here do we have these options? We do not have. So amongst the option, which is the best possible option? Let us have a look at this. Ketamine. What exactly is the role of ketamine in daycare surgery? Is it beneficial? Ketamine has got a very dreaded side effect in the form of post-op hallucinations. So in the post-operative period, we do not want any complications in this particular daycare surgery scenarios. So ketamine, because of its post-op hallucination, because of hallucinations that it results because of induction with ketamine or because of usage of ketamine, we tend to avoid ketamine in daycare surgeries. Yes, in general also nowadays we prefer to avoid ketamine because of the dreaded complication of hallucinations. Thiopentone, halothane, and pancuronium. Yes, which of the following amongst these can be used? Pancuronium, is it short-acting drug or long-acting muscle relaxants? Do we have a better choice available? Of course we do. So pancuronium will be preferred in cases of daycare surgeries? Of course not. Why? Because it is long-acting neuromuscular relaxants. So it is ruled out. Halothane, do we have a better option for halothane, and amongst thiopentone, do we have better drugs available? Amongst the two, halothane is a direct myocardial relaxant, direct myocardial depressant. It can cause other side effects in the form of halothane hepatitis. It has got higher blood gas partition coefficient, so it will take longer duration of time for recovery, and because of its side effects, either ways we are rarely using halothane nowadays. And we have got better drugs in the form of DES and CO available in our OTs. So yes, halothane is also not preferred for daycare surgeries. So what is left out by option of elimination is thiopentone. Yes, because of its redistribution profile. How is the recovery? Recovery from thiopentone is because of redistribution. So amongst the following options, thiopentone is the best possible answer. But yes, if propofol or desflurane was there in the answer, we would have gone with that. But since amongst the option, by way of ruling out, thiopentone is the best possible option that we have got here, so we'll go with thiopentone. Yes, the correct answer is option B, that is thiopentone. Next question, in which condition is the addition of vasoconstrictor to local anesthetic is contraindicated? Remember, vasoconstrictor to local anesthetic is contraindicated. Yes, generally local anesthetic in the form of lignocaine, bupivacaine, ropivacaine that we use nowadays. And what is the vasoconstrictor that we add in that? Most of the times we add adrenaline. Yes, so in spinal anesthesia, do we use vasoconstrictor along with local anesthetics? Yes. So lignocaine with adrenaline or bupivacaine with adrenaline can be used in spinal. If you look at the options, first is spinal, second is epidural, third is digital nerve blocks, and fourth is brachial nerve blocks. So if you look at the options here, by way of elimination also you can say that two of the following options, that is spinal and epidural, belong to central neuraxial blockades. Yes, both of them are acting at the same point, that is the spinal nerve roots. So even if you just apply a little brains here and logic, you can rule out option 1 and 2. What about option 3 and 4? Let us go into the details of that. In digital nerve block, do we require vasoconstrictor? What is a digital nerve block? Yes, in which we are blocking just a digit, that is just a finger is blocked for some debridement or amputation, partial amputation, KY or whatever be the surgery. Now for digital nerve blocks, since digital, that is digits, that is the fingers, are supplied by end arteries. What do you mean by end arteries? That means the blood supply to the digits, that is the fingers, is by end arteries. That means there is no further anastomosis or there is no collateral supply. Yes, if you block this artery, the blood supply to the digits, the fingers, will be blocked completely, and the digits or fingers will turn ischemic and further necrosis and gangrene can occur. So whenever you are adding vasoconstrictor to the local anesthetic, with the vasoconstrictor, what are you exactly achieving? You are achieving vasoconstriction. Yes, like adrenaline causes vasoconstriction. That is what the name itself is telling. So blood vessels will go into spasm, they will go into constriction, and the blood supply to that part will be hampered. Generally this is done to actually increase the duration of action. Yes, but in case of digital nerve block, since there are end arteries, and even if you vasoconstrict that, the blood supply to the fingers, to the digits, will be hampered. This can lead to ischemia and necrosis. Therefore, this is contraindicated in digital nerve blocks. What are the other places where it is contraindicated? Tip of nose, pinna, ear pinna. So all these are end arteries, penile arteries. Yes, for penile nerve blocks. You will avoid local anesthetic along with vasoconstrictors in such cases, because these are all supplied by end arteries. And once these are supplied by end arteries, what will happen? There will be chances of ischemia and necrosis and further gangrene of that part. So it is better to avoid. So therefore it is a contraindication to add vasoconstrictor to local anesthetic while giving digital nerve block. So brachial plexus block, epidural, spinal, yes, we do add a vasoconstrictor to local anesthetic to increase the duration of action, right? So correct answer here is option C, that is digital nerve block. Moving on to the next question here. Yeah, so where can you find me again? You can find me on this wonderful platform of Unacademy, where this is the plus batch course that is going on right now, that is concise batch course in anesthesia. We have just concluded 2 sessions. The other sessions are about to come up, and this is a very exciting course that we are going on with. The other batch course that I will be taking is the integrated batch course. Both the links are there. You can just click on the link, go on that session and enjoy those batch courses. Where can you find me on the Telegram group? You can find me on the Telegram group, that is Anesthesia Simplified by Dr. Hitesh, where we interact. We have poll based sessions. You can even ask me questions directly, and I'll give you updates of which lectures I'm coming up on Unacademy next. All those people watching on the YouTube, don't forget to subscribe and hit on the bell icon as well. Till the time we meet again, this is me, Dr. Hitesh, signing off for the day. Goodbye. Take care.